Numb toes and foot drop. General features. Although it might appear that these symptoms are most likely the result of peripheral nerve pathology, do not immediately exclude the possibility of central nervous system or combined, peripheral and central nervous system, pathology. In addition, the symptoms may be part of a more generalized disorder. Is the patient systemically well? Are there indications of any of the conditions? Look in particular for the following. Cachexia may suggest malignancy or alcoholism. Evidence of alcoholism/chronic liver disease. Vasculitic rash, probably indicating systemic vasculitis in this context. Signs of hypothyroidism, which can produce mild neuropathy. Postural hypotension, evidence of this is not likely to be available in PACEs, but it is an issue that could be mentioned in discussion likely to indicate an autonomic component. Neurological examination. Is this a peripheral or central nervous system disorder? Look for the following patterns as you examine the legs. Peripheral nervous system. Typical findings include distal weakness, absent ankle reflexes, with or without knee reflexes, stocking distribution sensory loss, wasting, if the problem is severe. If there is a loss of sensation to temperature, but preservation of proprioception, power, and reflexes, then consider a small fiber neuropathy. Central nervous system. Typical findings include spastic tone, weakness both proximally and distally, but predominantly in leg flexors, brisk reflexes, extensor plantars, possible sensory level on abdomen or higher. The arms may also provide useful information. Distal blunting to pinprick with absent reflexes indicates a peripheral neuropathy. Loss of dexterity, absent biceps and supinator reflexes, and brisk triceps reflexes, inverted supinator and biceps reflex pattern, suggests a lesion at C5 and 6 leading to cervical cord compression below this level, as well as compression of the C6 root. Are the signs symmetrical? In this case, asymmetry in the context of an upper motor neuron syndrome would represent Brown-Séquard syndrome, with loss of proprioception ipsilateral to the weak leg, and loss of pain and temperature sensation contralateral to the weak leg. Asymmetric lower motor neuron findings suggest mononeuritis multiplex or entrapment neuropathies. Further discussion. Hereditary motor and sensory neuropathy. This is common in PACEs. Note the following. It is divided into Type 1, demyelinating, Type 2, axonal, Type 3, Dejerine Sodas, and some other subtypes. Previously called Charcot-Marie-Tooth disease and peroneal muscular atrophy. Inverted champagne bottle legs, and similar process in arms and hands. Sensory abnormalities are much less prominent than motor ones. Lateral popliteal nerves are sometimes palpable. Subacute degeneration of the spinal cord. Vitamin B12 deficiency may cause a peripheral neuropathy but can also result in additional corticospinal tract and dorsal column degeneration, which leads to combined upper and lower motor neuron features. Either the peripheral nervous system or spinal cord may be affected first in the early stages, but objective sensory abnormalities usually result from posterior column involvement and less often from peripheral neuropathy. Early in the course, impaired joint position and vibration sense predominate. Typically the legs are affected before the arms. At presentation, 50% of patients have absent ankle jerks but are hyperreflexic at the knees. Their plantars may be flexor initially, but eventually become extensor. The clinical picture can be variable, but remember that this is a treatable condition and must not be missed.